Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Welcome to episode 1 of 4 of the Practice Changing Updates, the Evolving Hemophilia Treatment Landscape podcast series. I am Dr. Angela Weyand, Clinical Associate Professor of Pediatric Hematology Oncology at the University of Michigan. I am joined by my colleague, Dr. Guy Young. In this episode, we will discuss recent practice-changing updates in replacement and non-replacement therapies in hemophilia A. We will present key clinical trial data and discuss the safety and efficacy of these newly approved therapies. Recently reported evidence and its impact on ongoing patient care will also be assessed. So to start, I'm going to be speaking first on replacement and non-replacement therapies for hemophilia A. As probably most of you are aware, the treatment of hemophilia A has really evolved over time. Looking back to the 50s when the only thing we really had was plasma, then in the 60s, cryoprecipitate, followed by PCC and APCC treatments. And then in the 70s, really a big, shift in treatment with the development of plasma-derived factor VIII concentrates. Also in the 70s was the DDAVP, and then later in the 80s, luckily, after there were issues with viruses in the plasma-derived products, we had viral inactivation in the mid-80s for our products. But it really wasn't until the early 90s that we started to have availability of recombinant factor VIII products. And there has been evolution in this as well, with second and third generation factor VIII products coming in the early 2000s. And then in the mid-2000 teens, extended half-life factors being approved and available. We know that then, we've also had the development of non-factor products, including mimetics, as well as rebalancing therapies against our body's natural anticoagulants in the 2020s. And those products are either still in development or some recently approved. So thinking about factor VIII replacement therapy in hemophilia A, I think we all are, aware that there are pros and cons to the use of factor replacement. I think the a big pro is that we really are replacing what the patient is missing. We have the most experience with these products because we have a long history of using these. Going back decades, we know that they are relatively safe, although we do need to be aware that with all of these products, there is the risk of development of autoantibodies and inhibitors. We know that we can get peak levels into the normal range and can follow these levels and know really where our levels of factor VIII and hemostatic control are. We're able to give extra doses, and we're able to use the same product for prophylaxis as well as to treat bleeds or to perform surgical procedures or things that need extra hemostatic efficacy. There are cons as well, and I think our patients are probably even more aware of these than we are. They do require intravenous administration, which can be quite difficult, especially in our youngest pediatric patients. They have required 2 to 4 times per week administration, which really is quite a large burden of treatment, especially when you think about that intravenous administration. So these things together can make it difficult for our patients to adhere to their treatment plan. And many young patients, usually our youngest patients that have difficulty with intravenous administration, need ports, which come with their own risks, including infection and thrombosis. We know that factor levels do fluctuate and that when the levels come down at the end of the treatment interval, when patients are at those trough levels, there is bleeding risk at that point. So these are all things to take into consideration when we're thinking about whether patients should be receiving factor replacement therapies versus some of these newer products. So, as I mentioned, even when we think about factor VIII replacement products, there has been evolution of factor VIII products over time. Back in late 1960s, early 1970s, we had plasma-derived clotting factors. And then, as I mentioned, in the 1990s, were the first recombinant clotting factors. And this was really very exciting, given the fact that there had been widespread viral contamination And recombinant products really eliminated this potential for transmission of bloodborne pathogens. Then, many of you are probably aware, as we recognize this really high burden of treatment on patients, many companies looked to develop products that had more extended half-life that could be dosed less frequently. And so a lot of these extended half-life clotting factors were developed. And they did lead to, for some patients, to fewer infusions with similar outcomes to the standard half-life factor products. Similar to the extended half-life, they were safe products other than the risk of inhibitors, and are effective for surgery, prophylaxis, and treatment of bleeds, but still had quite, a high treatment burden, even with the extended half-life products that really weren't able to extend the half-life quite as long as we would have liked to. And we know that patients still continue to have bleeds on these products, so we're not able to fully prevent arthropathy. And there's also a pretty significant cost associated with all of them. So thinking about extending the half-life of factor products still within the realm of factor replacement products, there has been a significant extension of the half-life of factor VIII with the development of efanesoctocog alpha. So efanesoctocog alpha is a very highly modified recombinant factor VIII product that utilizes a number of different modifications to extend its half-life. So similar to some other extended half-life products, it has the Fc receptor to increase the half-life through that recycling pathway. There are 2 extend molecules that also increase the half-life. But probably the biggest thing is this D' D3 domain that is present, that is there basically to decouple the infused factor VIII product from the patient's endogenous VWF. As we've learned that VWF is really limiting the half-life of the infused factor VIII, and decoupling the factor VIII that's infused from the endogenous VWF can really extend the half-life greater than what had previously been able to be achieved. And so with this, in the Extend 1 trial, looking at patients who'd previously been treated with factor VIII products, they had a lead-in study where patients received what, between themselves and their healthcare providers had been determined to be an optimal factor VIII treatment regimen. In the pre-study, their ABR was 2.96, and then they entered into the study and got standardized dosing of 50 international units per kilo once weekly of efanesoctocog, which actually decreased their ABR by 77% down to an ABR of 0.69 on once weekly prophylaxis. And obviously with this pre-study prophylaxis, these patients were receiving infusions much more frequently, between 2 and 4 times a week, but still with much less treatment burden, had a pretty significant decrease in their mean ABR. And as expected from data that we had from earlier trials, with these modifications of the factor VIII molecule, there really was pretty significant extension of the half-life. So this is pharmacokinetic data from the Extend 1 trial, which shows, we're still achieving very high normal levels of factor VIII after infusion that then obviously decrease over time, but out at that 7-day interval when patients are about to infuse again, really still are in the 12 to 15% range, and patients are actually above this kind of 40% normal level for over half of the week. So a much longer half-life, allowing for this once weekly dosing, still with troughs much higher than patients have been able to achieve with other factor VIII products. So looking at some more data on efanesoctocog alpha, there was also the Extend Kids study, which looked at children, again, with severe hemophilia A. These were also previously treated patients, but they went down to, less than 6 years of age. It was 0 to 12 years of age patients, and patients, again, received the standardized dosing of 50 international units per kilo once weekly. And as you can see, the median ABR was quite low at 0. And the mean ABRs, the overall was less than 1. 6 to 12 was a little bit higher, and less than 6 was a little bit lower. I would hypothesize probably due to the kind of level of activity in the patients of varying ages. But really the primary endpoint in the study, primary outcome, was the incidence of neutralizing antibodies to factor VIII, and there were no inhibitors that were detected with the trial. It, similarly to the adult study, did show that the vast majority of bleeding episodes were able to resolve with 1 50 international unit per kilo injection, and that the vast majority of bleeds that were treated, the response was rated as either excellent or good by the patients. There were 2 patients who had 2 major surgeries during the trial, and their hemostatic response was also deemed as excellent. So overall, data pretty consistent with the adult data, showing low ABRs and good responses to just 1 injection as far as bleeding treatment. And then looking at the pharmacokinetics in children, most of you are probably aware that younger patients tend to require more frequent dosing and have lower troughs than adults, and that is what we see here. So, but again, much extended half-life compared to other products, getting, those normal factor levels after infusion, and then going out to day 7 when patients are redosing, having trough levels in the 6 to 7% range. So still ending up with patients being above that 40% or normal level for a little less than half the week, but still, remaining quite high even towards the end of the week. So we're going to go now to our first polling question, which will be about some of the things that we just discussed. So which of the following are true for efanesoctocog alpha? A, it is a factor VIII replacement therapy. B, it is designed to decouple recombinant factor VIII from endogenous VWF or von Willebrand factor and overcome the VWF imposed half-life ceiling. C, it could be provided as a once-weekly intravenous infusion. D, all of the above. Or E, none of the above. So looking at the results, I think everyone is brilliant in the audience, with 100% of our participants choosing all of the above. So yes, it is a factor VIII replacement therapy. It has the extended half-life, largely due to the decoupling from endogenous VWF, and it can be provided as a once-weekly intravenous infusion. So moving on to kind of the next product that we wanted to talk about is the first non-replacement agent that we'll discuss this evening, which really, when it was approved, allowed us to overcome a number of the limitations that we know are present with the use of factor therapy. So we know that the missing protein in hemophilia A is factor VIII, and that really the action of factor VIII, activated factor VIII, is really to bring together activated factor IX and factor X on the phospholipid membrane. And so the thought with emicizumab, which is the first factor VIII mimetic that has been approved, there are others in development, but emicizumab has been available for a number of years and really acts to mimic this action of factor VIIIa by bringing together activated factor IX and factor X, again, on this phospholipid membrane, to fill the role of factor VIII when it is missing. And because it is not a factor VIII molecule, one benefit of it is that it can be used in patients with and without inhibitors. It can only be used for hemophilia A, as you would imagine. It's filling the, mimicking the action of factor VIII, and so would only be effective in those patients that are missing factor VIII. Its pharmacokinetics are very different than factor replacement in that there are no peaks or troughs, and you have much more steady state hemostatic coverage. So you're not able to get that 100% factor VIII equivalence, but you also aren't, dropping down to a lower level before you get your next dose. And then additionally, one huge benefit that we've seen, especially in the pediatric population, is its subcutaneous dosing for administration. And so it doesn't require intravenous administration. It can be quite helpful in avoiding the placement of ports that I had mentioned earlier that can be challenging in our youngest patients, as well as some older patients, but tends to be more of an issue in our youngest. So imicizumab has been studied in a number of different settings, and this is kind of a pooled analysis of long-term results from the phase 3 studies, so the Haven 1 through 4 trials in people with hemophilia A, looking at annualized bleed rates. And so as you can see here, this is a treatment interval over time, so 1 to 24 weeks all the way out to 121 to 144 weeks. And as you can see, kind of earlier on, the ABR is a little bit higher, but then as you get further out, it is quite low, less than 1, and is pretty consistent. And this shows here the percentage of patients with 0 and 1 to 3 treated bleeds, the percentage of those patients, again, over certain treatment intervals. And as you can see here, similar to a little bit higher ABR to begin with, and then dropping down to more steady lower levels. You can see here that initially about 70% in that first 1 to 24 weeks had 0 treated bleeds. And then the increase was pretty steady at a higher level at those longer treatment intervals. But, with this, nearly 3 years of follow-up, these low bleeding rates are maintained. And the imicizumab is also very well tolerated over this longer term follow-up that has been done. So looking specifically at the different Haven studies, this is looking at patients who had 0 treated bleeds in a number of different settings. So the very first Haven study was just done in patients with inhibitors, specifically adolescents and adults with inhibitors, and looked at once weekly dosing prophylactically, and 63% of those patients had 0 bleeds. The next study, Haven 2, again, only looked at inhibitors, or patients with inhibitors, but went down to the pediatric ages and again looked at once weekly dosing, and 86% of the pediatric patients had 0 bleeds. Then the later studies looked at patients that didn't necessarily have inhibitors. So Haven 3 was a study of adolescents and adults without inhibitors, and looked at both weekly as well as every 2-week dosing, and had 56% of patients in the Q weekly dosing group that had 0 bleeds, and 60% of those in the every 2-week dosing group that had 0 bleeds. And then lastly, Haven 4 actually looked at every 4-week dosing, so approximately once a month, and looked at adolescents and adults. These could be patients with or without inhibitors, and even going out to that once every 4-week dosing, 56% of patients had 0 bleeds over the course of the study. So this brings us to our next polling question. Imicizumab has been studied among pediatric patients, so ages 2 to 11 years of age, with severe hemophilia A in which of the following trials? Haven 1, Haven 2, Haven 3, or Haven 4? And now there's been even more Haven trials, but just looking at those first 4. Perfect. So Haven 2 is the correct answer. So the Haven 1 was patients with inhibitors that were adults and adolescents, versus Haven 2 was, again, patients with inhibitors, but was in the pediatric studies. And then Haven 3 looked at those different dosing regimens of once a week and once every 2 weeks without inhibitors. And then Haven 4 was looking at that once every 4-week dosing interval.
Thank you for listening to episode 1 of Practice Changing Updates, the Evolving Hemophilia Treatment Landscape. Please join us for episode 2.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.